so good to be back. I hope you and your family are well indeed. It's been quite a while since I last posted a video, and it's just so amazing to be back doing what I love, sharing both my passion of internal medicine with you as well as my passion of living for the Lord Jesus Christ. God bless you. And it's my joy and privilege to be commencing a new series, which I have entitled the Overview Series. Here, in each video, we will be tackling a particular clinical problem and breaking it down. So usually, there's going to be a clinical case to start us up, and then some helpful information in a question and answer format, making it somewhat targeted and kind of more easy to understand and digest. And I hope this is going to be a helpful resource for you and a blessing as we strive to become better physicians. But first up, some humor as always. Now, since we're talking about jaundice, I thought I could deliver a few jokes. So, once a man was having a failing liver, and his doctor tells him that he needs a transplant. The man then asks his doctor if it is necessary. The doctor replies, "It's liver die." And then ever wondered what kind of fish can perform a liver transplant? Well, a sturgeon. Okay guys, let's break it down. Jaundice, this is our clinical case for the day. So we have a 43-year-old female who presents to her primary care physician with fatigue and malaise, very non-specific kind of constitutional symptoms right there. On routine lab, she is found to have an aspartate aminotransferase of 150 units per liter, which is high, an ALT of 165 units per liter. This is alanine aminotransferase. So both of these are the transaminases, both of which are high. A total bilirubin of 25 micromole per liter, also high, and an international normalized ratio of 0.9. Now, which of the following best describes this particular pattern of liver function tests? Is it A, cholestatic, B, cirrhotic, C, hepatocellular, D, mixed, or E, peritonitic? Good question. So let's just break down jaundice for a bit. What is jaundice really? It is a clinical condition characterized by yellow discoloration of the skin and mucosa due to excess bilirubin in the blood. Clinically, it's seen when your bilirubin exceeds about 51.3 micromole per liter. Now, jaundice should be assessed in natural daylight, not in artificial light. And as we know, bilirubin has a very, very strong affinity for elastic tissue. So the sclera in the eye contains plenty of elastic tissue, also the skin as well. Hence, jaundice is best appreciated in the sclera. So clinically, you're going to ask the patient to look straight ahead while you lift the upper eyelid and ask the patient to look down, and you can observe the jaundice in the sclera there. Remember that keratinemia from excess keratin can also cause yellowish discoloration of the skin, but not the sclera. Not the sclera. So how do we classify different types of jaundice? So we divide into prehepatic, intra, and posthepatic, and this beautiful illustration is courtesy of our colleagues up at MedComic.com. Shout out to you guys. So prehepatic causes of jaundice includes things where there's excess breakdown of red blood cells and liberation of bilirubin into the bloodstream. So here we're talking about things like anything which causes hemolysis, essentially. So transfusion reactions, sickle cell anemia, malaria, thalassemia, autoimmune diseases, and so forth. Intrahepatic causes of jaundice, there's something intrinsically wrong with the liver. So as we can see, the liver is sick, right? It can be hepatitis, it can be cancer, cirrhosis, congenital disorders, and drugs. And of course, the causes of cirrhosis are many. Posthepatic is a problem essentially with the bile ducts or some kind of blockage or obstruction distal to the liver. So here we're talking about gallstones, inflammation, scar tissue, tumors, PBC, which is primary biliary cholangitis. The nomenclature has changed over the years. Primary sclerosing cholangitis. All of these block the flow of bile into the intestines. Alrighty, so here are a few of the Q&As. What are the types of congenital non-hemolytic hyperbilirubinemia? So there's 4 types essentially, 2 of which are unconjugated and 2 conjugated. So of the unconjugated flavor, we have Gilbert syndrome and Crigler-Najjar syndrome. The conjugated forms includes Dubin-Johnson syndrome and Roche's syndrome, where there's a problem of conjugation. All right. And usually the enzyme involved there is UDP glucuronidtransferase. Okay, so when we're encountering a patient with jaundice in clinical practice, what history is absolutely essential? And you know, the fundamental basis of medicine is your history taking, your physical examination. So the physical examination merely serves to confirm what your history already picked up. And then you go on to investigations and management, right? Those are the pillars. So in a jaundice patient, you want to ask about anorexia, nausea, and vomiting. Why? Because this speaks to the cause being probable viral or drug-induced hepatitis. What about the color of the stool? Look, if it's pale stool with dark urine, you're thinking more an obstructive cause for the jaundice. However, some patients may have portal hypertension, which causes esophageal varices and upper GI bleeds, in which case the stool can be dark as well. Itching, which is pruritus, also lends more to obstructive jaundice. If there's a family history of jaundice or consanguineous marriages, and the patient also is pale, you're thinking more along the lines of hereditary hemolytic anemia, the likes of thalassemia and friends. Sexual exposure points to hepatitis, especially hepatitis B. Is there a history of injection, infusions, or blood transfusion where you're thinking, okay, does the patient abuse IV drugs? Are they a heroin addict? Do they have any tattoos? Have they undergone surgery? That points more to hepatitis B and C. History of travel abroad, hepatitis B, and sometimes when you travel abroad or even locally, you may be exposed to possible contaminated food, water, milk, and other items. Then you're thinking about the hepatitides, which are transmitted by the fecal-oral route. That's namely hepatitis A and hepatitis E. Is there a history of alcohol or other drugs which points more to cirrhosis? Is there associated fever, or are there any urinary complaints, especially with conjunctival suffusion, which makes you think about leptospirosis? Is there recurrent jaundice with a neurological abnormality, something that always points to Wilson's disease, which is hepatolenticular degeneration? Is there associated abdominal pain with fluctuating jaundice? Do you think about a bile duct stricture or a stone? Yeah, that's the history. So looking at the different kinds of jaundice, what are the common features of these different classifications of jaundice? So, features of pre-hepatic jaundice, usually we said in the setting of hereditary hemolytic anemia, we were looking for a triad. 3 features, which is anemia, jaundice, and splenomegaly. Also, if the patient has frontal or parietal bossing, mongoloid facies, then you're thinking more about those hereditary friends like thalassemia, etc. And then other features depend on the cause. Commonly, malaria. What about autoimmune hemolytic anemia? Look out for the concomitant features of these conditions. If you're looking at hepatocellular jaundice, these patients often have a history of anorexia, nausea, vomiting, weakness, and clinically the liver is enlarged and tender. Features of obstructive jaundice, here we spoke about the pale stool, the clay-colored stool, the pruritus. There may be abdominal pain. There could be a mass in the epigastrium. And other causes of obstructive jaundice depend on the cause, like xanthelasmata and primary biliary cholangitis. Remember, these patients with obstructive jaundice have a problem secreting the bile into the intestine. And the claim to fame of bile is that it emulsifies fats. Now, if you can't emulsify fat, you can't digest and absorb your fat dependent factors. And the fat dependent factors, as we know, are A, D, E, and K. And if you can't absorb your vitamin K dependent factors, you have a problem with bleeding. And of course, the vitamin K dependent factors, you think of, they were made in the year 1972. I say, what? 1972? All you got to do is add a 0 in here, and you have factors 10, 9, 7, and 2, which are the vitamin K dependent factors, right? Yeah, these patients with obstructive jaundice also tend to have bone pain due to osteomalacia because you can't absorb your vitamin D. Alrighty, so then quickly, how to investigate jaundice? Well, I'm glad you asked that question. A good place to start is with your liver function test, where you do your albumin, your serum bilirubin, your ALT and AST, which are your transaminases, your alk-phos, which is alkaline phosphatase, and gamma-glutamyl transferase, which are your cholestatic enzymes, and your international normalized ratio. Remember that if you have a low albumin with a high INR, that speaks to diminished synthetic function of the liver. If you have a low albumin and a high INR, diminished synthetic function of the liver. You want to do an ultrasound of the hepatobiliary system. You're looking for features of hepatitis in the liver. You're looking for features of ductal obstruction. You look at the dimensions of your extrahepatic bile ducts, which speaks to an obstructive cause, etc. Right? You look for any intrahepatic lesions, like if there is a cyst, is there a mass lesion, is there an abscess? Okay. Viral markers you want to do, especially for your hepatitis viruses, your anti-hepatitis A IgM, your anti-hepatitis E IgM. Regarding hepatitis B, you want to do your anti-hepatitis B surface antigen, your anti-hepatitis B E antigen, and your anti-hepatitis B core antibody, as well as your anti-hepatitis C antibodies as well. And other investigations are dictated by your clinical suspicion. So if you're thinking about hemolytic anemia, it's prudent to do an hemoglobin electrophoresis. An obstructive jaundice may be an ERCP, which is endoscopic retrograde cholangiopancreatography. MRCP stands for magnetic resonance cholangiopancreatography. The big advantage of ERCP over MRCP is that obviously you can intervene with an ERCP. So if there is a cholangiocarcinoma or a suspicious lesion, you can go and do brush biopsy, right? If there's a stone, you can retrieve that stone via ERCP versus MRCP, which is merely an investigative imaging modality, not really an interventional modality. You might also want to do CT of the whole abdomen as well. So back to our case, right? So we had a young female with non-specific symptoms, constitutional symptoms, with a high transaminases, high bilirubin, and INR, which is normal. So my friends, this is hepatocellular pattern of liver function test. And examples of hepatocellular disease are viral hepatitis, autoimmune hepatitis, alcoholic liver disease, where there are features of liver injury, inflammation, and necrosis that predominate. Alrighty. Guys, that was jaundice, and as always, please allow me to encourage you from the Bible. The Bible, we should always love what we do, right? And the Bible encourages us to do this. Because the book of Colossians, chapter 3, verse 23, here Paul admonishes the Colossians by telling them, in whatever you do, work at it with all your heart as working for God and not for man. Galatians chapter 6, verse 9 says, never become weary of doing good, for at the proper time you shall reap a reward if you do not give up. God bless you, brothers and sisters. This is Ryan signing off. It's good to be back. These are my references. And I'll catch you on the next video. God bless you in abundance.